The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk.
You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers.
Welcome, Sky Women. You're listening to this after I have done a deep dive at Menopause Society meeting, which I will do a separate podcast episode on things learned from that at a later date. But I have been wanting to go over this clinical expert series on the contemporary view of menopausal hormone therapy by Dr. Levy and Dr. Simon for a while. It's been in my bag. I've been toting it around. I've been intending to record. And here we are. We're just going to run through it today. So this might be a little bit raw, but what I want us to take away is kind of where we are, why physicians might hesitate to prescribe menopausal hormone therapy, and what we currently know. The past year, there's been significant increase in public attention around menopause. And I feel like, please beware the snake oil, friends, because so many are coming out of the woodworks trying to make a buck off of menopause. I feel like I'm the OG because I've been doing this for a long time. So I don't want you to be taken by some of the snake oil options and the direct consumer marketing supplements and devices and products that are trying to make you think that they're going to make your menopausal symptoms better without any scientific support. So I think it's really important that we kind of look at kind of why we're in this state and the history of menopausal hormone therapy. So, this was discovered in the 1900s and it was being used wildly, or I should say regularly. And then the Women's Health Initiative, which is the largest randomized controlled trial that we have, designed to look at postmenopausal hormone therapy and whether or not it should be offered to all women to reduce the incidence of cardiovascular disease. So this is why there was an older age. The average age of women in the Women's Health Initiative was actually 63. And so this massive, expensive undertaking enrolled 160,000 women at a budget of $600 million. And in July of 2002, the NIH press conference announced their preliminary findings that focused on the harms identified with conjugated equine estrogen plus medroxyprogesterone acetate. Did it mention the significant benefits in the reduction of osteoporosis or osteoporotic fractures or colon cancer? Nope, none of that was mentioned. It was just this focus. And we've already talked about in the past how they got this wrong, that, it does not cause breast cancer, but there were a few extra cases of breast cancer in the estrogen-progesterone arm, but a significant decrease in the estrogen-only arm. But as a result of this, there was fear publicly around the risk of menopausal hormone therapy, and prescriptions plummeted 79%. Now, the women who were enrolled also really were asymptomatic. So these weren't symptomatic women. These were women who were postmenopausal, and they were looking at, should we give them hormone therapy to reduce their cardiovascular incidence? So it was set up to look at cardiovascular disease. So this confusion and fear among healthcare professionals and the public has led to this perfect storm. What I was taught now I graduated from residency in 2010. What I was taught about hormone therapy was lowest dose for the shortest period of time. But I think it's important for us to understand that preservation of function is not typically equivalent to prevention of disease. And as we look at this data, and it's been detailed, looked at in great detail in the years since, we know that the patient population was a decade over the average age of women undergoing menopausal transition. And it's not hormone formulations that we're typically using now. We're not typically using conjugated equine estrogen and medroxyprogesterone acetate. So that is curious, or it's not curious. I mean, it's just that this is what when we know better, we do better. Now, there is an instance where I'll use a conjugated equine estrogen, and that's when I use Duave, which is conjugated equine estrogen with beta-doxythene, which acts as a selective estrogen reuptake inhibitor or modulator, rather. And so it's anti-estrogen at the breast and the uterus. And so we use this in patients who want to avoid progesterone or don't tolerate progesterone for whatever reason. Some of my previvors are, BRCA carriers who have had their breast and their uterus and ovaries removed, sometimes even will use it for the benefit of bone density. Now, what we know from the Women's Health Initiative of the 16,000 postmenopausal women with the uterus who were on that combination of estrogen, conjugated equine estrogen, and medroxyprogesterone acetate, it was stopped early because of that increased incidence of breast cancer, as I mentioned. The trial was not a breast cancer trial, right? It was important. It's important for us to note that the randomization was for baseline cardiovascular risk, not for baseline breast cancer risk. And when you go back and look at it, in 2018, Hodis and Searle did a review critically evaluating breast cancer risk through the lens of those WHI. And they found that that combination of hormone therapy in typical postmenopausal women who have never used hormonal therapy had a null effect on breast cancer. But in the trial, many of those who were randomized to that arm actually had used hormone therapy in the past, which decreased their incidence of breast cancer. So the breast cancer incidence was not affected by the conjugated equine estrogen plus the medroxyprogesterone acetate if you compare that to a placebo group, and that's up to 11 years. It was the unusually low breast cancer incidence in the placebo group in the Women's Health Initiative that created this controversial breast cancer data. So just so that we're clear kind of where we stand with that. The magnitude of conjugated equine estrogen and medroxyprogesterone on breast cancer is similar to the risk, other host factors like obesity is a risk factor for breast cancer, low physical activity, and drinking 2 glasses of wine a day. So that's important for us to kind of take into consideration. Now, we very often use micronized progesterone and estradiol, which are our bioidentical options, for lack of a better term, but they're mimicking what our body has always made. The most significant finding, and often overlooked, is there was a 45% decrease in breast cancer mortality in the conjugated equine estrogen only group for 18 years of cumulative follow-up compared to the placebo arm. So this is not a small finding. Let's talk about estradiol and cardiovascular disease. The Danish osteoporosis prevention study was randomized over 1,000 patients on 2 milligrams of oral estrogen plus a progestin, if it was indicated, or no hormone therapy. And they followed them for up to 16 years. And during the 10 years of treatment compared with the placebo, there were lower rates of myocardial infarction or MIs, heart failure, and death, with no increase in blood clots, cancer, or stroke. Now, the DOPS was terminated early because of the Women's Health Initiative published findings. There remained a significant improvement, though, as they continued to follow women at 16 years. Even though women from the Dobbs trial stopped menopausal hormone therapy with the 2002 publication of the WHI, they were still followed. And at 16 years, there remained significant improvement in rates of MI, heart failure, or mortality, even 6 years after exposure to hormone therapy. Just strengthening the case for cardiovascular protection with estradiol. We know that cardiovascular risk is influenced by age and time since menopause. Even looking at the Women's Health Initiative 13-year follow-up documented that the group initiating menopausal hormone therapy between the ages of 50 and 59 had a 40% less or lower MI risk, myocardial infarction risk, and lower all-cause mortality than the placebo group. So these significant event reductions are seen in younger women, but they didn't extend to the women over 60. And that's why we have that timing hypothesis or the gap hypothesis, which is related to our natural cardiovascular risk in relationship with menopausal hormone therapy. Okay, let's talk about menopausal hormone therapy and blood clots, because that's often a concern as women start considering, should I be on hormone therapy? What options are available to me? What are my risk of having a blood clot? If we look at biomarkers for thrombosis or that clotting, a higher level of activated protein C was found in people on conjugated equine estrogen users. In 2014, Pacific Northwest published a large study looking at individuals 30 to 79 years of age from 2003 to 2009, with the average age being 68.5 years. And they were looking at blood clots with conjugated equine estrogen compared with estradiol. While we know that blood clots increase with age, the risk of blood clots increase with age, there appears to not be an association with estradiol when administered via the skin transdermally or with micronized progesterone. So this is what we're typically using in hormone therapy, and there does not appear to be a increased incidence of blood clot with that delivery. And so it's very important whether diabetic or hypertension, that obviously well controlled, obesity, these are individuals that we're really going to try to steer towards a transdermal option versus an oral option. But you probably heard me say before that with oral estradiol, there is an increased incidence of blood clot, but it's relative risk. So transdermal, really, you're at your baseline risk for the average population of having a blood clot on an oral estrogen. So if that's 2 out of 10,000, an oral estrogen is about 4 out of 10,000, but on a birth control, that's 9 or 10 out of 10,000. And pregnant is significantly higher, postpartum is significantly higher. So it's a relative risk. Despite the fear of both patients and oncologists, low-dose topical estrogen, let's talk about vaginal estrogen. This is really important. It appears to be safe even for people with hormone-sensitive cancers. We have ACOG has a consensus gynecology statement specifically on this. Low-dose vaginal estrogen for individuals with a history of breast cancer, including those taking tamoxifen. For individuals who are taking aromatase inhibitors, low-dose vaginal estrogen can be used after shared decision-making between patients, gynecologists, and oncologists to try to always incorporate the oncologist into our decisions there. But breast cancer survivors deserve clear communication that it will not compromise survival, and it can definitely improve their sexual function and their quality of life. So no increased incidence of breast cancer or mortality with a local vaginal estrogen. Now, a very common question I get is, can I take vaginal estrogen and systemic estrogen? And the answer is absolutely yes. If you're on a systemic estrogen, that's addressing hot flashes, night sweats, moodiness, agitation, etc., helping with our prevention of osteoporosis. But oftentimes it does not affect the genitourinary syndrome of menopause. So if somebody has painful penetration, urinary urgency, frequency, etc., decreased lubrication, fissures just when you wipe, this is when we want to add in a vaginal estrogen. So there's a lot of errors in extrapolating a beautifully designed randomized controlled trial, the Women's Health Initiative, to a population and hormonal formulations that were studied in the trial, aren't really being used by the vast number of women in menopausal hormone therapy. Healthcare professionals need to know the true risk and benefits of the various hormone formulations. Currently, there's little recognition by healthcare professionals and very little training on menopausal transition, which I just saw that the Menopause Society got $5 million for menopause education. And so I'm excited to see how this gets extrapolated into potentially programs for educational or for residency programs to help teach all of our physicians because oftentimes our family medicine doctors, not just the OBGYNs, but oftentimes the family medicine, internal medicine doctors are the ones who are on the front lines and can help to identify this because oftentimes well-meaning patients go to their PCP, get their labs drawn, and they're told, you're normal. Everything looks great. And the patients leave feeling gaslighted because they're like, but I don't feel normal. Something is not right. And that often leads them down a road of years of suffering and going to multiple providers, trying to get the help that they need. What about prevention? So, one of the Menopause Society lectures was on longevity or health span. We know that women live longer, we're outliving men, but oftentimes in poorer health. And I always say, I don't want to live long if I can't live well. And I want to help my patients to live well. We definitely have data to support that. It's one of the indications for menopause therapy is the prevention of osteoporosis. Now, does it treat osteoporosis? No, but it can help prevent osteoporosis. We know that it helps to preserve cardiovascular function. And I don't think this is data that we can ignore. And I think that as we increase research dollars in menopause hormone therapy, we will see more and more its benefit in longevity. But I would say that the data is still to be determined. But I think we're seeing it much more. And we know that individuals 65 and older who are on hormone therapy versus who discontinued or never used hormone therapy actually have less incidence of heart attacks and breast cancer and colorectal cancer and dementia, Alzheimer's, osteoporosis, etc. So the data is there to support that. We just haven't looked at it specifically. Let's talk about some of the alternative therapies. So, fear of breast cancer with hormone therapy has caused many people to search for alternatives. And oftentimes, patients come with a bag of supplements that they're using, trying to feel better, but oftentimes still missing the mark. There's no evidence to support the value of these supplements. Interventions, I should just be very clear that, transdermal estradiol, microdose progesterone are generally very safe. They're FDA approved. You do not need to get compounded medications typically to get the relief that you need. So typically you can get FDA approved medications that are covered by your insurance, which patients are often floored because they're spending several hundreds of dollars on compounded formulations or getting pellets and injected and oftentimes are tired of the roller coaster and are delighted to find out that this is going to be covered by their insurance. ACOG does not, or American College of OBGYN does not recommend routine testing of hormones or FSH to determine menopausal status or direct therapy. Typically, it is your symptoms that are directing your therapy, but that doesn't mean that you would never test your hormone levels because sometimes it means you're questioning whether you're absorbing it. And we may want to look at that. But we don't need to affect your FSH in regards to hormone therapy. There's not one value of estrogen that says, oh, this is where everyone's going to feel wonderful. That's just not how it works. So we have to take into account the menstrual history, evaluation of symptoms, examination, and it's kind of the key in determining that menopausal status and what and where we need to go from there. But the FDA has approved a neurokinin 3 receptor antagonist for the treatment of vasomotor symptoms. And that's fezolinetant or Veosa. And it reduces vasomotor symptoms associated with menopause, and about 60% of those randomized to the treatment compared to placebo. So all of these things work for some and not for others. And so we just want to, make sure that we're offering some of the non-hormonal options like fezolinetant or Veosa. We also have serotonin selective reuptake inhibitors or serotonin norepinephrine. So these antidepressant medications that have often been used for hot flashes. And a lot of times patients come in frustrated because they're like, I'm not depressed. I just need my hot flashes or night sweats to go away. And for some, it helps. And in others, it does not. Gabapentin can also be used off-label for hot flashes and night sweats, and some people use this successfully. It also has its own set of side effects. Also cognitive behavioral therapy, clinical hypnosis, weight loss, stellate ganglion block. These are all things that can help with the hot flashes and the night sweats. But they carry their own risk that are not insignificant. Now, when it comes to testosterone therapy, we talked about estrogen and progesterone a little bit, but testosterone therapy is the one that gets such little attention. If we're going to dose testosterone, it is indicated for hypoactive sexual desire, and we use 1/10 of the male FDA approved version. And we have step by step on how to do this through the International Society for the Study of Women's Sexual Health. But typically, we're recommending that we trial it for at least 3 to 6 months to see, do we have an improvement in those symptoms? And we get baseline testosterone level, and then 3 to 6 weeks after starting therapy, and then another 6 weeks after on hormone therapy. And if we're stable in a premenopausal female physiologic range, then we test every 6 months. We estimate that 6,000 women enter menopause every day. This should be very compelling for us all to understand the risk and the benefits of hormone therapy. We need to stop extrapolating this randomized controlled trial of women in their 60s that took conjugated equine estrogen and medroxyprogesterone to recently menopausal women who are taking these isomolecular formulations like estradiol and micronized progesterone. Our current system for grading the evidence in evidence-based medicine hierarchy has neglected to consider the population studied and the true patient population that we need to be applying these guidelines to. We know that women's increased risk for cardiovascular disease, bone loss, and dementia start with hormone loss at the time of menopause. Women who lose their hormones early, like premature surgical menopause or premature ovarian insufficiency, they have accelerated rates of osteoporosis, heart disease, and cognitive decline unless they're put on proper hormone therapy. So, newer studies looking at estradiol and progesterone are smaller and shorter in duration than the WHI. We are unlikely to get another study like the WHI. We can't apply the data found in the WHI to early menopausal population. The pendulum has swung from not treating menopausal women with hormone therapy, which is exciting. The evidence supports the use of estradiol for osteoporosis prevention, for the treatment of vasomotor symptoms, for the prevention of cardiovascular disease and premature death when it started within 10 years of menopause. Adding micronized progesterone further enhances bone mineral density, so that is exciting, without an increase in breast cancer incidence or mortality. We didn't really get into the specifics on progesterones, but I have a separate podcast episode about that. So, to prevent harm to the public, the titles and conclusions of publications need to be really scrutinized because I feel like this is the big downfall to the WHI. Well, we've received a ton of data that was incredibly helpful in the WHI, but taking a contemporary approach to menopausal hormone therapy involves really looking at the specific patient, their health risk, their health history, their physical exam, their most bothersome symptoms and complaints, etc. So taking that comprehensive approach where we're getting a full set of labs, we're looking at underlying causes. For instance, a particular patient, just in the last week, I know of, came in with all of the symptoms of menopause, but I get a complete set of labs to look at, do we have, how's our liver functioning? How's our kidneys functioning? Do we have any cardiovascular risk? Do we have a thyroid disorder or vitamin deficiency? And we found vitamin D deficiency, insulin resistance, of course, cholesterol is elevated, our typical metabolic syndrome. And we can't just treat the hormone therapy without looking at the whole person and addressing those underlying causes and implementing this approach of helping the women live with vitality, to live longer, to reduce that insulin resistance, to improve those cardiometabolic markers. Now, hormone therapy can help with a lot of that because we know that with estrogen deficiency, we see more insulin resistance and we see that cholesterol panel worsen, but it's not the only treatment. So all hormones are not equivalent. And there's got to be something better than just giving patients antidepressants. And we just really have to look at the right treatment for the right patient, knowing that different formulations are different, the right dose and timing for the patient matter, so that patients can have safe and effective and appropriate treatment for their menopausal symptoms. And we know that we do not have to discontinue hormone therapy at the age of 65 just as because they're too old. That's not the case, or because they've reached the age of 60. This is old rhetoric. We know that for health and longevity, hormone therapy can be very beneficial, and many women continue to have symptoms in later years. And so we should not take away their hormone therapy just ambiguously. Thanks for listening, and thank you to Dr. Barbara Levy and James Simon for a timely review on menopausal hormone therapy. The central message for listeners is simple but powerful. Hormone therapy is not a one size fits all. It's not the same conversation we had in 2002. Modern evidence shows hormone therapy remains the most effective treatment for bothersome hot flushes and genitourinary symptoms. And when used thoughtfully, it can improve sleep, mood, bone health, and quality of life. So, what does that mean for you? As someone going through perimenopause or menopause, first, timing matters. Starting hormone therapy earlier in the menopause transition or within 10 years of your final menstrual period generally carries a different risk profile, and starting later. And that changes how we weigh benefits versus risk. Second, the type and route of hormones matter. So there are multiple estrogen and progestogen options. A local low-dose vaginal estrogen for urogenital symptoms versus systemic hormone therapy, and each choice should be individualized to your symptoms, health history, and priorities. For people with a uterus, adding the appropriate progestogen remains essential for protecting that endometrium. Third, shared decision making is everything. If you're suffering from hot flashes, sleep disturbance, painful intercourse, or reduced bone density risk, talk to your clinician experienced in menopause care at menopause.org, and you can search for a physician in your area by zip code. And together, you can review your personal risk, like clotting or breast cancer risk, symptom burden, goals of treatment, to design a plan that really fits your life. And finally, if you've been told in the past that hormone therapy is categorically unsafe, know that the science has evolved, and so has clinical guidance. And if you want, our clinical resources and the Menopause Society are good steps to find reliable information and referrals. And this episode, I hope we've helped you feel more confident about modern hormone therapy and how that might be applied to your life. Share it. Let's keep updating the conversation. Menopause care should be evidence-based, individualized, and empowering. Until next week, be well.